Good morning, everyone. So I'm assuming that a large proportion of the audience today is PT, correct? Am I right?
Yes, ma'am.
Okay. And how many OTs do we have in the group?
I think one or two.
Only one or two. Okay. And we have only two at Amar Seva, is that right?
Yes, ma'am. Only two.
And
Three.
we have three. Okay. And how many speech therapists do we have?
Speech therapist is one, ma'am. Most of them are speech trainers.
Okay. I'm just sharing my screen and the meanwhile. Okay, so what's going to happen today is there's going to be a lot of content. It's also going to be a fairly heavy and technical session. I'll try and give you all a few breaks in between. And maybe as sections are complete, I'll ask you if you have any questions at that point. Okay. The idea today, Dhanalakshmi, I think your speaker is on or not. Okay. I think the idea today is to give you the foundations of what SI and sensory processing are, the neurology behind it, what modulation is, what affects modulation, and we'll create a toolbox for activities in the coming session, whenever that is. Yeah. All right. So just a little bit about myself. I was hoping to conduct this actually in person when I was at Amar Seva, when I was going to be at Amar Seva this weekend. It didn't work out, unfortunately for me. So I'm an occupational therapist. I'm based in Mumbai, India. I'm a pediatric therapist and I have my own clinic with 12 therapists in Mumbai, and I work at a tertiary care center as well. Most of my research has been on family-centered services and has been on technology use in therapy. All right. So when we talk about sensory processing, I'm going to ask questions. So I'm hoping people are interactive and I get answers. Okay, when you think of sensory processing, what are the main things that you think about? What when you think of sensory processing or sensory integration, as it's commonly called, what do you think of? Anybody can answer. This is not a test. I'm not judging you. I don't even know who's talking. So it'll make more sense if it's interactive. So when you think of sensory processing, what does it mean?
Hypersensitive, hypersensitive,
Okay.
and
So hypo or hypersensitive. All right. I'm going to at this point, hold on. Okay. I'm going to present you with a case. Celine, I'm going to use the cases you sent me for the next round of discussion we have. This is a girl. She's in a classroom. She's 8 years old. Okay. The mom says she's a very sweet girl, very likable, has a lot of friends, but she takes a very long time to finish her schoolwork, even though she keeps trying. Okay. She's extremely quiet in class and she leans forward on the table and stares into space. She dislikes craft activities and she's very clumsy. Okay. I'm not asking questions at this point. I want you to list down all the difficulties you think this child has. Just list them down. You all are already doing assessments, I know that. So if you had to identify difficulties this child has, can you please list them down? I'm giving you a minute. Okay, another question. Typically, do you all have screens on during training programs or they're always off? Okay, are we done? Yes. I'm not going to ask you what you've written. I just need to know if you're done with this so that we can. Selin, I have a question. Typically during in-services, do you keep the screens on, or are the videos on?
Oh, ma'am, typically there is no video on, ma'am.
There's no video on. Okay. Okay. I'm moving to the next case then. We are going to come back to this later. So I suggest all of you please keep your papers with you. Okay. The second section, the second case is about Z. Okay. He's what they called a busy bee. He gets up and he's constantly moving, never sits in his place. He has a rubber band and he's constantly pulling it or twirling it around his hand. When he's seated in the chair, he's constantly rocking back and forth, back and forth. Okay, a written work is done, but always off the lines. So never on the lines. All right. So can you list down all the difficulties you think this child has? I'm not talking about diagnosis. I'm talking about sensory issues you think this child has. All good? Okay. Shall I just pick on people and ask, or does anybody have any questions so far about these two cases? You'll have finished and you'll have written down, because we'll come back to them in a little bit. Okay. Typically, I would ask your questions here, but I'll come back to it in a little while. We're now going to review the theoretical background behind sensory processing. So as a therapist, right, as a therapist growing up, SI was a very big deal. Sensory integration to me was, using swings, going into this colorful room that we didn't know existed. That was, only certain people were allowed in because it was fairly prestigious to be let in, because it was considered to be difficult to handle. Um, now, the theory behind SI is the information has to get integrated, but we also need they've realized that it's a process. Okay. So right now there is a shift between sensory integration. It's called air sensory integration, and it's moving towards sensory processing now, because it's a whole spectrum of things that's going on. Okay. Now, when we think about the pyramid of learning, I would like everyone to type in the chat box, what do you think are some of the components that you need to learn? What are some of the components that you need to learn? Can you please type in the chat box? Can everyone hear me okay? Can I have a thumbs up or something like that? Okay. What else? Read in here. Okay, good. Anything else? You guys are about 20 of you. Behavior, okay, good. Understanding, all right. Attention, good. Hand on, I don't understand what hand on means. Keep going. Practical demonstrations for learning, okay. Attention seeking, teaching, sensory seeking, okay. Needs to be able to read and write, good. Okay, excellent, excellent suggestions here. And this is typically what we're going to do. I'm going to have you all chat into the type into the chat box. What you need to remember is when we are learning, reading, writing, listening, seeing, all this requires a large number of things. Okay, so this is called the pyramid of learning. Okay, and I'm going to come back to this image as well at a later point of time. You have all your sensory systems over here, your tactile system, your vestibular system, proprioception, gustatory, auditory, visual, and olfactory. Now, what I want you to pay attention to is there are two layers of sensory systems. All of them are important 100%, but the tactile, vestibular, and proprioceptive system are the foundation of the foundation. Okay, so they have the equal place for top three. Does that make sense? Yeah. And then you have the sensory, other sensory systems that build up on top of it, right? So once you have your sensory systems that have developed, then you have the sensory motor components that come into play, which would be postural security, awareness of the two sides of the body, motor planning, ability to screen input. Okay, first. Now, when we talk about tactile sensory system, what does that mean? Can we type? What does tactile system mean? Touch. Yes. What is the vestibular system? Moving, hearing, movement, balance, and proprioception. Okay, so vestibular is definitely balance. These go together for sure, the balance and the proprioception. Okay. What else does the vestibular system mean? For balance, movement, the organs for hearing are located in the same area as where the balance is. The balance is generated, but the vestibular system is more for balance. All right. Let's talk balance and equilibrium. Yes, very good. What about proprioception? What does that mean? Correct. Position, joint position sense, very good. Okay. So, there's been some, that's correct. So when I was a student, my understanding of proprioception was just that, joint position. Okay. In the past 5 to 10 years, there's been changes even in the concept of proprioception, where they talk about conscious and unconscious proprioception. Okay. Something that happens where you are aware of it and something where you're not. And there are different pathways for it. I'll talk about it in a few minutes. But proprioception definitely is position sense, and it involves stretch receptors. Okay, I'll talk about that. I'll show you all diagrams and stuff like that. It involves your vestibular system for being upright, and it integrates your tactile system as well. So very often you need to remember that the tactile, vestibular, and proprioceptive system are all working together. Okay, there are some contraindications to the tactile and vestibular system, but not for the proprioceptive system in terms of use. So I know we as therapists love using the swing, okay, but you need to be highly cautious while using swings and scooter boards, because there are a fairly large number of negative effects that can happen if they are not used appropriately or used for too long, right? Then we have the olfactory system. Can anybody tell me what olfactory means? Perfect, smell, yes. Visual system, the visual system, vision. So anybody want to elaborate on vision? So vision is seeing, correct, right? But besides vision in terms of seeing, we are also doing something else, right? We are registering things within the environment, right? Um, so that's something that I'll talk about a little more. Auditory. What is auditory? Hearing. Hearing, correct. And what is gustatory? Taste, correct. So I will not touch upon gustatory much today because oral motor is a different issue and a different topic by itself that requires a lot of education. But there's one sensory system missing here, right? Called the interoceptive system. Interoceptive, that is now known as the eighth sense. Can anybody tell me what interoception? I'll just type in the name over here. Um, can anybody tell me what interoception means? Organ sense. The feeling from within, right? Your feeling from within. So I will be highlighting what interoception is, because there's again new research that talks about what interoception is and how it impacts performance. Thanks. Okay, now we're going to understand that this is the base foundation. Once your sensory systems are working fairly well, you then have the motor component that comes into play. Okay, we have all these reflex. I don't know if it's popular in the south, but here we'll have intermittently people who are doing reflex integration training and postural stability training. Is that a common thing? Is that a common thing in the south? I'm asking because I don't know. Chat box is great if you want to just let me know. Is that a common thing? Reflex integration, yes. Okay. There is very suspicious data that's available, not very much data that's available that says that this works or is impactful. As a therapist, what I have seen is that over time, integrating reflexes become easier once we have the sensory systems in place and the child can follow instructions to work on reflexes that will improve functionality. So I'll come to that in a little while. Okay. So now when we talk about body scheme, I'll just explain what these things are fairly quickly to you. It's the ability to understand your body. This is my face, my eyes, my nose, my ears, my mouth, and my hair, right? And so if you ask a child to draw, they'll be able to draw the face appropriately in the body, even if it's a stick figure. And the body scheme is important because then if you, for example, do an activity where you're putting shaving foam on the child's hand, close their eyes and tell them to rub it off, they can correctly identify where the shaving foam has been put on their body. If the representation of the body in the brain is not appropriate, that will not happen. Okay. Reflex maturity. A lot of children today have non-integrated ATNR, STNR. So for example, if a child is swimming, I'm giving you a random example here. If a child is swimming, right? So you guys can also see me, correct? Yes? In addition to the, yes, okay. So for example, when you're swimming and you're doing a forward stroke, right? You need elbow extension, you need to look up. So if somebody has non-integrated ATNR and STNR, this is going to be a very difficult task for them, all right? If they are sitting to write down from the board and they are looking, okay, so they have non-integrated ATNR and they are writing on the table, the teacher goes from left to right, they lose their position at midline because the reflex is not integrated. We know this to be true, right? So reflex maturity will happen only at a later point of time then. Ability to screen input. Now, what does that mean? That means if I'm looking or if I'm sitting in the classroom, my friend is talking, the teacher is talking, there are birds outside, somebody's walking in the corridor. So the ability to shut down all that information and just focus on what the teacher is saying is what sensory motor ability is here. Okay. Postural security, knowing that I can sit on my chair without toppling over and falling down. Awareness of two sides of the body, realizing that left and right is different. And motor planning. Now, this becomes very important because if you tell a child, so developmental coordination disorder is a very was a very hot topic maybe 5-6 years ago. DCD. I mean, children are still being diagnosed with it, but it's a very small percentage of children who have DCD. And there are standardized tests that are gold, like the BOT is a gold standard test for it. Um, Typically, what happens over here is the child has difficulty with planning. So if you give them an obstacle course, a fairly complicated obstacle course, and tell them go from A to B, right? They have a really hard time planning how to move their body to get from one point to the other. This is an extreme example where the child is, cognitively normal, where the child doesn't have any problems with um, IQ, with no restrictions or limitations in terms of motor skill. Motor planning is basically what that is there purely in the DCD sense. But if you have a child with autism, for example, and you give them one of my favorite activities at home, right? When we're doing home therapy is I'll give you a basket of onions and potatoes, maybe 4 onions for potatoes. I will put a stool, I will put a higher stool, I will put a pillow, and I will tell the child you have to go over these pillows and stools, like on top, up and down, and you have to put it in the basket at the end. Now, for them to be able to do it without falling, holding on to the potato is planning for them, right? So that's what I mean. It depends on the diagnosis. Motor planning is a component, but it varies in terms of difficulty based on the level of the child and what the diagnosis is also. All right. I just quickly need to know, am I going too fast? Have I broken it down enough? Do you want, is it too simplified? Can someone let me know so that, or like a couple of you let me know? Is it too simplified? Selin, is this level okay? Or Ram, is this level okay? Speed is fine. What about content? Go slow, go slower. Okay. Okay. What about the content? Is the content appropriate? Is it okay? Little slow. Okay. Okay, fine. So I am going to make it a little more scientific. Okay. So it's going to get harder in terms of content. So please unmute and tell me if you need me to go even slower. I'm happy to do that. All right. Okay, so once you have your sensory and your sensory motor development, what you have then is the perceptual skills. Can you write and tell me in the chat box, what do you understand by perception? All these things for sure, but can you give me an example of what a perceptual skill might be? So we know it includes all these things, okay? Hand coordination, postural adjustment, attention. So in the classroom or in real life, what we see and understand, right? Concrete examples, perception, where would you as an adult need to be able to perceive things? I'll give you one example. I'm leaving the house in the morning. I have a big bag. I have to find my keys. There are 500 things in my bag. Okay. I'm looking. The ability to feel, to look, and to identify what's different, right? Um, is an example of what perception might be. You can give me concrete examples like that. Okay. When you all do interventions, do you all do perceptual sheets with your kids? Do you all do sheets, printout sheets? Odd one out, or do you all do join the dots, or do you all do complete the diagram or mazes? Yes or no? No, you all do not use worksheets at all or activity books with your kids for drawing, draw within the lines. No. Okay, those are all perceptual tasks. Okay, and once your perceptual tasks are in place, you can go to higher functioning like academic learning, behavior, and activities of daily living. Okay. Always remember that the evolution is from bottom to top. Okay. Now, this is a very typical image that I show all the time, where you have functional range, which means all of us have our sensory systems that need to be here. If a child is hypersensitive or overstimulated, they're over here. And if they're hypersensitive, they're over here. He said this already, right? This is the functional range. If you're understimulated, hyposensitive, okay, you're over here. Now I'm going to ask, I want examples from a lot of you right now. What do you understand by hyposensitivity? Give me an example in the chat box. What do you all understand? It doesn't have to be the right answer. So when we say tactile hyposensitive, right, it means they are a seeker, right? Like Mai said. What that means is they are seeking sensation because they are understimulated. So you might have a child who is touching walls, touching people, playing with poop, um, making a mess wherever they can. Um, okay, no. So when we say hypo means less, sensitivity is sensitive. Typically, kids who are hyposensitive are have seeking behavior. Okay, so you are right. They have low levels of stimulation, but they are seeking very often more. So when they seek more, they're touching things or they're moving a lot or they're eating hard foods if they're oral seekers. Absolutely correct. Um, and then you have the other end of the spectrum where they are overstimulated, right? So they might be defensive. So if they are defensive, what are some of the things you might see? If they're hypersensitive, what are some of the things you might see? Avoiding, correct. They're defensive, exactly. So what are some of the things you might see? They avoid soft foods or they only prefer soft foods sometimes. What else? Right. So you might have toe walking. You might have tactile defensive who don't let you touch, correct? Irritability to hard objects like the floor, yes. To tags on the back of your shirt, yes. They avoid loud noises like firecrackers, like pressure cooker, Absolutely correct. Excellent, guys. Good. Okay. Okay, so we've already done this where we have our sensory systems and you have all the sensory components here. If you all have not read this book, The Out of Sync Child, I highly recommend you read it. It's a great book. It's really good. It has lots of examples. They have a newer version, I think, that came out in 2012 or something like that. That was also very, very good. Okay, so we just discussed already what. So I just want to highlight here. Your skin is a tactile organ. Okay, you touch for the registration. Okay, but that's not your tactile sensory system. Your tactile sensory system is somebody touches you, your brain registers it and gives you an output, whether to absorb, to ignore, to respond. That is the whole circuit together is is a sensory process. All right. So hearing also, you hear, you listen, your brain registers, and you give an output, oral or physical. That is the whole circuit. So if you take away one thing from today, that needs to be the most important part. It is that you get sensory input to the brain from your sensory organs, and you give an output which also might be from the sensory organs only. Okay, so this is one second. This is your fetus in utero. Okay, this is the dark blue is when the point up until with which major birth defects can occur. Okay, the light blue means it's still developing and there is a possibility of some defect. All right, so if you look here, your nervous system is evolving throughout birth until the 38th week, which is 2 weeks before your full term. Okay, so now with the evolution of twins, triplets, children being born, like I at my clinic, I myself only see really young babies under the age of 1. So I do regular sessions for them. And these children are 24 weekers, 26 weekers, precious babies, all of them. So can you imagine the neurological, they come with a lot of issues, let's put it that way. Okay, and normal full term for twins, for example, is 36 weeks. Okay, normal delivery as in what is considered full term for triplets is 33 weeks. So somewhere over here. So the evolution of the brain, the space in utero is already compromised because of the number of fetuses, and that so the birth rate will definitely be low to begin with. That in addition to all the evolution of the different body parts is also going to be impacted. Okay. So I want you to focus on the central nervous system over here, and you are also going to look at the ears over here. Okay, the development of the ears also continues consistently. So let's talk here. Okay, so when we talk about this, right, touch starts at 5.5 weeks in utero. So the fetus can feel touch, and 9 weeks vestibular and proprioceptive systems are already working, of which the vestibular system is the first to mature. Okay, now in utero, why or when do you think the vestibular system might be impacted in the fetus? Can you put it in the chat box? Think about complications during pregnancy, and when do you think the vestibular system could be impacted? Anybody in the chat box? No? If you have a mother on bed rest, right, they are not moving, right? So the fetus is getting some movement in utero because they are floating. but there is deprivation to their vestibular system as well because they aren't getting the movement that they typically would have. All right. Okay, so now we've completed this base part over here. So now I'm going to open it up and ask you, do you have any questions so far? Yes, no? Any questions? No questions? Okay. So Jane Ayers came up with this concept of sensory integration. Okay, this was in 1970. So the assumption is that this is a process that organizes sensation from one's own body, from the environment, and allows you to use your body effectively within your space. Okay. It's an automatic process that is out of control. So these are her theories from when she came up with it. However, it's a neurological process that is malleable and responsive to treatment. Okay, so this was her model. You had all the sensory systems here, right? There was intake by an organ, there was integration in the brain. The brain then selected, inhibited, enhanced, compared, and associated the sensory feeling that it was getting. Okay. We then planned and organized the behavior based on what was required. So, what this means is if I'm sitting in a classroom and the teacher is writing something on the board, I'm looking at the board, I have to select my posture. Like I have to actively remember that I have to copy from the board. So my body needs to be upright. I need to stop listening to what my friend is saying. I need to focus on the words written on the board. And I need to write what is written on paper. Okay. Um, so this allows us to adapt behavior. So shutting down, listening to my friend and focusing on written work is the process and slowly gets better and better and results in more written work being completed. And so the sensory loop is complete. Okay. So practice is very important. Changing the way in which a certain task is accomplished is also important. And motivation is very, very important. Okay. Now, I mean, as a student, the thing that I heard a lot was the child needs to be motivated. The child needs to be motivated. I agree the child needs to be motivated. It makes your job easier. But neurologically, does anybody have an answer why motivation is important? Does anyone have any ideas? Yeah, motivation increases attention. Absolutely correct. Why is motivation important? Motivation is very important because it helps the child focus, right? And allows you to accomplish a task. Now, what is the key over here is when you're creating a pathway in the brain, when there is motivation, there is increase of dopamine released from the neurotransmitters. Okay. Dopamine helps us focus and attend. So if you are trying to improve attention and behavior, doing a motivating task for the child becomes extremely important. All right. So that's the science behind it, the dopamine. Now, if, for example, you want the child to do a motor task and they love books, okay? So the child hates movement but loves numbers or loves books. You incorporate that and hopefully you get a slightly higher level of motivation and that's your starting point, right? So you will have to be creative in terms of the type of activities that you do to get the child to perform better. Okay. Now over here, I want you to look at these. There are two different classifications. Okay. This is the old classification in 2007 for SPD, sensory processing disorder, where they looked at three base types. One is a sensory modulation disorder, where you have an over responsive child, you have an under responsive child, or you have a sensory craving child. Then you have a sensory based motor disorder, that is like dyspraxia or postural disorder. And then you have a sensory discrimination disorder, like the child can't discriminate between pain or what's being said or smells or understand interoceptive sense. So this is what was created by Miller in 2007. Okay. Do you all understand? Do you all, do you all understand terms like dyspraxia? Do you want me to explain it to you? No? Okay. So, okay, praxis is movement and this means unable. So when there is no appropriate movement or there is difficulty in praxis, it is called dyspraxia. Apraxia means no. So you have an apraxic child, a child who can't talk because they don't know how to move their tongue inside the mouth. Okay, that is an example of oral apraxia. Dyspraxia means they are doing it, but they probably don't know the motor components that are broken down to replicate it the second time. Okay, so this means inappropriate or difficulty with praxis movement. All right, very commonly seen in children with DCD, developmental coordination disorder. And a postural disorder is basically where you have slouching or you have this movement where the child is all over or is only lying down. Very commonly, you will get a complaint from the teacher saying he's leaning constantly or she is leaning constantly. Um, she has difficulty sitting upright. Okay. When we talk about sensory, okay, one second, I'll come to the SOR and all this. Let me just go to I'll put this. Sensory over responsivity means you have somebody who is defensive. Okay, you have someone who's tactile defensive, somebody who is vestibular defensive or gravitationally insecure. Gravitational insecurity is a term. So in the olden days, we used to classify it like that, where if you have a balance beam, okay, which is just something that might be 2 or 3 inches high, and the child has to walk on it. Um, they can't because they're afraid. So I have a 13-year-old currently coming to me who's in an ICSE school, mainstream school, but has low tone, has intermittent eye contact, has gravitational insecurity. So forget a rock wall that I have at my clinic. He can't even do a balance beam that is just this high because he starts sweating, he gets palpitations because he's so afraid, right? Then you have sensory under responsivity, where you have somebody who's just sitting like sitting like a sloth or a, either they're sitting like a sloth or a potato in one place, right? They're not moving at all, or they're basically touching everything, making a mess, jumping. Um, and then you have the sensory craving. These are the people who are constantly in the move and constantly touching 100 different things for sensory feedback because their neural loops are not complete or they're not getting enough feedback. Okay. So now this is the newer classification. I don't know, I'll be talking about the types of different assessment tools as well. So there's been a big shift in recent times where people have moved away from they moved away from things like the sensory, the SIPT, and now there's a new tool called the EASY that's coming out, EASI. I'll talk about that a little bit in a bit. Okay, now according to this, they've divided it into 5 different components, right? The first is poor sensory perception. So the ability to distinguish between pain and touch, for example, is something I very commonly see in my clinic. So we might be doing deep pressure with a child, and all of a sudden you might see insane laughing or giggling, right? Because the transmitters that carry the sensory information are not working correctly, have not been activated in the past. So the child doesn't know how to respond to the feedback. If he might enjoy it, but he's laughing uncontrollably because it's not registering appropriately in the brain. Okay, that's just an example. Vestibular and bilateral integrative VBID. So balance, equilibrium, and using both sides of the body are difficult in this group of people. Somatodyspraxia is sensory and motor performance is affected in people who have somatodyspraxia. So they might apply excessive pressure while writing. That's a very basic and simple example. Visual dyspraxia, they can't figure out differences between the lines. They can't figure out close and far. And then finally, you have sensory reactivity, which is hyperreactive or hyporeactive, like we've already discussed earlier. Okay, so this is the newer classification that we have in 2015. Okay, so very commonly what I use as a parent report is a sensory profile. Okay, and they have the toddler one, and they have an adult one also now, and they have three different versions. The SIPT, I've used it a couple of times. It's extremely tedious. You have to be certified to use it. Okay, and okay, you have to be certified to use it. The sensory processing measure, which is also a questionnaire, and it's fairly good. I just use a sensory profile because I'm most familiar with it, and I trained with Vinny Dunn when I had started my PhD. So I'm more familiar with it than the sensory processing measure. They have two versions of this, and the final one is the easy evaluation in ear sensory integration, which is supposed to be more fun and better adapted for most environments, and very little stuff in terms of equipment required. And it takes about an hour and a half typically. Okay. So I'm going to talk about why it happens. All right. Do you have any questions at this point? Anybody in the chat? Okay, so we're going to take a 5-minute break after we finish. Yeah, so after we finish the etiology, etiology means cause. Okay, there's no known cause for SPD. Research has shown that there are some factors like preterm birth if the child is under 2.2 kilos. So if you have a low birth weight baby, if you have a premature birth, children born within less than 32 weeks, right? So they typically present with sensory processing difficulties if not stimulated enough by the time they're 4 years old. If there's excessive parental stress, like a death in the family, abuse, things like that, alcohol and drug consumption in pregnancy, and certain genetic factors and exposure to chemical agents during childhood could also cause SPD, right? Very often I have parents, so I practice in an area of Mumbai called Bandra, the which is the suburbs. It's not South Bombay is different. So what typically happens is I might have a chartered accountant father and an engineer mother who have some traits, but then the child will come in with full-blown autism. So there are genetic factors that when you take the history also, the father will say, oh, but I did this exactly like this when I was a child, and the mother will say, oh, I did why just like he does right now. So sometimes it's a combination of these two factors that result in X plus Y equals to Z kind of deal. So that's what you typically see. Okay, in ASD, in autism, 80 to 90% of the cases often have SPD. Okay. There's a very strong correlation with ADHD, with Down syndrome, with opsoclonus myoclonus syndrome, with epilepsy, with atopic dermatitis, okay, which is bizarre. And very often there's urinary incontinence as well. They was associated the urinary incontinence to difficulty with interoception. Okay, so we'll talk a little more about that later. And children with SPD have a 4 times higher risk of developing emotional problems like anxiety due to external behaviors. So they might be very anxious and distressed about something, but it might come out as aggressive, right? So what people accept and understand as cues for being afraid, especially if they're cognitively high functioning. I'm not talking about autism, I'm talking about SPD over here, where it typically is shown to be aggression. Okay. So we're going to take a 5-minute break at this point, and then I'll come back to the model. Do you have any questions at this point? I'm open to discussion. Okay. I'll see you in 5 minutes. Okay. Hi, everyone. I'm back. So let's talk about this was Ayer's this was Ayer's representation of what it needs to look like. Okay, you look at the child with SPD features, you identify what the issues are. Okay, you look at their preferences so that you can create the just right challenge, right? So remember that motivation that I was talking about, that helps you create the just right challenge. That's a very key component for her therapy sessions. Then you get active participation. So doing things to the child don't work. Okay, it's basically having things actively done, like, and this is with anything in life, right? The more you do, the more you learn, and that causes behavioral. Are you guys just seeing it now? You couldn't see it before? Can you see my screen?
Yes, ma'am.
Okay. Um, so that causes neural plasticity to happen in the brain every time you do it. So what I typically tell my parents when I'm doing it, right, is you have to repeat or practice something at least if it takes 1,000 times for a typically developing child, a neurotypical child. Um, if you have a child with special needs, you might need to do the same thing 2,000 times, right? So repetition becomes extremely important to create that neural pathway, and slowly restructuring of the sensory system occurs, and it helps improve performance in activities of daily living. It improves their self-esteem. It allows them to have better modulation in terms of emotion because they're not so upset or anxious all the time. So there are multiple areas that it hopefully impacts. Okay. Okay. Now I'm going to talk about the brain. All right, and how the different sensory systems are connected to the different lobes in the brain. So you all know the brain stem, the old wives' tale, or which is not a wives' tale actually, which is true. If you get a blow to the base of your neck, you can die, right? So that is where your brain stem and the cerebellum are this area is located. Why? Because your breathing center, your primitive breathing center, your arousal levels, everything is located in that area. All right. Now, some important things, your frontal lobe, that's right in front over here, right? Then you have the motor cortex and the somatosensory cortex here. You have the parietal lobe. you have the temporal lobe, and you have the occipital lobe. All right. I want you to remember these components as we go further. If you need me to come back to this, ask me. I'm happy to go back. Okay. Now, this is the frontal lobe. Okay. This is your frontal lobe. This is your motor cortex. This is your somatosensory area. Okay. This is where this is also your frontal cortex only. Okay. This is your parietal lobe over here. This is your occipital, and this is your temporal. Now, I want you to type out and tell me, okay, if I have somebody who has difficulty processing auditory information, which lobe do you think, or what part of the brain do you think they might have difficulty with? In the chat box. Okay. And if you have somebody who has difficulty with position in space, position in space. Okay. And if you have somebody with emotional difficulties, good. All right. So when we say the frontal cortex, right, it is the more evolved part of the brain. You also have the prefrontal cortex. Okay. So all your executive functioning, your high level of emotional acumen, all that happens in the prefrontal cortex, and we're going to talk about that in a while as well. Okay. Now, this is the blue that you see. Okay, you're looking at the typically developing brain here, and you have a child with sensory processing difficulties. Okay, what you need to look at here is this is the front part of the brain. In children with sensory processing difficulties, apparently the white area in this part of the brain, the posterior part of the brain, is less. Okay, so this is the back view here. This is the lateral view, and this is if you're looking from the top. Okay. Okay. So can you see the activation? This is an fMRI. This is the functional MRI, is basically when they're doing a task and the MRI is on. This is the only way to see which parts of the brain are getting active. Sorry. Okay. Okay. So another important concept that I want you to be aware of is the DMN, default mode network. Okay, in autism now, this is a very important component where the DMN is a network that allows a person to continue working when he's not focused on the outside world. Okay, so can you give me an example in the chat? What do you think that might be? Like, when do you think that might happen? Correct. Okay, so I guess my question to you is, do you think the person is focusing on everything happening outside or everything that's happening inside their body? outside or everything that's focused, or they're focusing on everything that's happening inside their body? What do you think they're focusing on? Maybe type that first. Correct. So, you know, this concept of hyperfocus that you see in children who have autism, what that means is they are so involved either on a particular task or within themselves, they are not focusing on anything outside within the environment. Does that make sense? Yeah. So they have a damaged DMN. Okay. Their default mode network is not activating at all. Okay. So there, this is recent, this is 2021, where it's called a locked out state. Okay. So they don't know how to break in and get into the DMN state because they're out of the DMN state because they're hyper focusing so much. Okay, so because of that, as therapists, as physios and occupational therapists, you have to focus very hard on activating the system to make them more aware of the outside world. Okay. Okay, before we go ahead with the tactile system and all that, so all of you know literature that says how children love playing games on the iPad, right? Or on phone, or use technology so well, correct? So what do you think is working when, do you think the DMN is working when they're doing that? Just yes or no. If you all can type yes or no. So you have a child on a phone who is playing some kind of a game. Okay. Do you think the DMN is working or not working? Is this a difficult concept? Should I break it down a little more? No? Yes? Yes? Okay. So the DMN, okay, causes a child to hyper focus. Now, what is hyper focus? Hyper focus is when you are studying and you are so immersed in it that you shut out everything else, you can register the information better. That is the assumption. Okay. So that is when your DMN is working. That is when your DMN is working over time. Okay. So in a child with autism, the DMN is working 100% of the time. Okay. And then you have another rest mode network that is not activating at all. Okay. That is not balancing it out at all. And because of that, we have an issue. So as therapists, we need to break that pattern and also activate the other mode network, the non-work mode network, okay, to allow the child to start focusing on the environment. So if you do effective therapy, the first thing your parent will tell you is, he was not looking at me before, now he is. So eye contact, which is one of the most important qualifiers for ASD, not the only, but one of the more important features, right, is because your DMN is overactive and the child is not interested in the outside world at all. Okay. So what these people did was they did a systematic review. Okay. And they looked at the work in the default mode network in both rest and task. Okay. This is, so basically you just remember that in ASD, the most important thing is that the child only has the default mode network on, and so can't be paying attention to anything else within the environment, and so we have to break that pattern. Okay. So now I was asking you about when they play, when a child on the spectrum or any child plays plays the phone or iPad or whatever game, there has been an increase in younger children who have developed ASD-like features through the lockdown, right? Because what were parents doing? They were at home, they didn't have help, they were giving their child the phone. So when you look at the phone, you have really quick visual feedback, right? Every second there's a new slide that's going in front of the child. It's activating the visual tract. The child is hyper focusing on that, and the other rest system is completely shut down. So there's no balance. So the child is not interested in interacting with the environment. And it almost creates cocaine like analogs in the brain. So it's like a chemical release in the brain that's addictive. All right. So that is why we do not recommend any kind of iPad use for children under 2 years. Now, India does not have these milestones written down. The American Association of Pediatrics has written this, saying that for children under 2 years, there needs to be zero screen time, because this is when your brain is most neuroplastic, right? And they're constantly evolving. So the more screen time they watch, the more their brain is learning that particular thing, right? And so they develop those symptoms fairly quickly. Does this make sense now? Is it easier to understand for everyone? Yes? Okay. Okay, great. So let's go on to the tactile system. What I want you to see over here, right? You have two sensory, you have the brain, okay? You have your dorsal, you have your, here, 1 second. You have one pathway over here, okay? This is for pain, and you have this that is for touch, all right? Now, what I want you to look at is the covering of the neuron. Here, okay, at every node, there is fast conduction because of the myelin sheaths. And here it is 1, okay? So pain is one of the first neurotransmitters to evolve, whereas touch is more refined. You have different types of touch, and I'll talk about which type of touch is, you have different protocols like a Wilbarger protocol and all that, which you need to be very cautious of, because it can cause negative effects in children if done incorrectly or if done with the wrong type of brush. Okay. At one time it had become a big rage, and you have to be extremely cautious about things like that. Okay. So you have different types of receptors in your skin. It goes to the from the skin. The touch receptors take it to the brain. Okay. We know where the somatic sensory system is in the brain. It's over here, right? Okay. Just remember, your fingertips have 3,000 receptors. The hand has 100,000, and your tongue and fingertips are the most sensitive. Now, this is the receptor that will tell you about cold and pain. These are the receptors that tell you about heat. Okay, this tells you about cool sensation, and this tells you about pressure. So there are different types of receptors, but the bottom line is pain is the first to be, like, if you have trauma and if your tactile system is affected, like a head injury and your tactile system is affected, pain very often is the first sensation to come back as compared to the others. Okay. Okay. Now we're going to talk about the proprioceptive system. Like I said earlier, okay, it allows you to figure out your position in space. Okay, you all also identified that very well. But remember that it is a combination of the stretch receptors in the muscles and the inner ear that identifies motion. Okay. The dorsal column is primarily responsible for touch and proprioception, while the ST is responsible for pain and temperature. So this is the primary difference between the different neural pathways. The auditory cortex we know is in the temporal gyrus, in the superior temporal gyrus, and different sound frequencies are mapped differently into the auditory cortex of the brain. Okay, now for your visual system, the information goes from the eyes, okay, and it's registered in the brain, okay, and this is through the thalamus. It allows us to identify color, shape, orientation, and movement. I've had 3 children in my practice time, 15 years, that have had olfactory systems majorly affected. And they were constantly, they had a smell box, they were smelling armpits, they were smelling all kinds of things. And if you turn the brain upside down, this is the bulb. So if you're turning the brain upside down, this is the cerebellum and the RAS and all, and this is the frontal lobe. Your bulb is located over here. It helps in discriminating odors, enhancing detection of odors, filtering out backgrounds, different odors, good from bad or something better smelling than the other, and also is related to arousal of attention and discrimination. Okay. And finally, we have the vestibular system, where you look at receptors in the inner ear. Okay, so remember, your inner ear has your saccule, your vesicle, and your semicircular canals, and each of them are responsible for movement either side to side, front to back, or angular. This goes to the brain stem. From the brain stem, it goes to the cerebellum, it goes to the oculomotor nuclei, the spinal cord, the thalamus, and the cortex. Okay, and because of that, it affects so many different things. Your vestibular system, if you don't give appropriate input, can cause very dramatic hyperactivity, vomiting, disorientation, if used inappropriately. Okay. Okay, now before we go ahead, I want you to list, one second. Okay, I want you to list all the sensory systems that I've spoken about so far and make 2 columns. So you're going to do tactile. One second, I'll show you what I mean. Okay, so what you're going to do here is you're going to do so you'll write tactile, and you'll give me one example of hypo, one example of hyper. Okay, like that you're going to do it for all the sensory systems so far. You're going to write it and we're going to discuss it in 2 minutes. This is for all Are you guys done with your list? Okay, if we go through the sensory system and first we talk about the tactile system, can you give me one example of tactile hypersensitivity? Excellent. So if you are a seeker, just remember it like this. For any sensory system, if you are a seeker, that means that your brain is not registering it properly enough. So there is less amount of information reaching high up and registering. So you want more. That's why you're touching, that's why you're jumping, that's why you're walking on your toes, that's why you're flapping. And if you are an avoider, that means it's registering too much. Yeah, wearing garments, right? Your tags are basically a problem. You don't want to be, you want to be without socks and shoes. Okay, and this is important because let's talk about interoception now. Okay, they are physiological and physical conditions of the body. They're internal sensors that provide a sense of what our internal organs are feeling. So you have some children who are constantly eating all the time, children who don't realize that they have to go to the potty, right? So remember I had said urinary incontinence is very strongly associated with SPD. This is what I meant. Okay. So toileting, how they are feeling, they don't know, they can't express their emotions. So that is another way interoception is impacted. Yes, please ask questions.
Ma'am, this is Maheshwari.
Yeah.
So some people,
Mahi, I'm sorry, I can't hear you very. I can't hear you very well. Hello.
they have both, no, ma'am. They avoid something and they seek something like that.
Yes, absolutely. So it's
Can you?
extremely, yes, yes. So it's extremely possible for a child to have the receptors in the brain represented, but the pathway that's carrying it is either overreacting or underreacting. So sometimes it seems like they're excessively reacting to something, and sometimes they're not reacting to it at all. Okay. So like Mahi said, so very typically what we might see is vestibular seekers. Okay. Vestibular seekers. So vestibular is a foundational sensory system. Okay. And typically there is no modulation in that. So if you're a seeker, you're typically a seeker. But from a tactile and an oral sensory perspective, it's very, very possible that you could be a seeker for some things and avoider for other things based on the texture. Mai, does that answer your question? Because the part of the brain that registers certain textures or certain temperatures is different. Yeah. All right. So two things. I don't think I've made a slide. Okay, let me finish this and then I'll talk to you about the tactile system a little more because I think that was quite interesting. The interoception, okay, see, is located in this area, right? So if this is, if these are the quadrants, right? So this is what it is, anterior insula. So the anterior insula is in the frontal lobe, okay? where there is a lot of emotion, where there is some overlap with the temporal and parietal lobe as well, right? So it's a fairly large area that's impacted. Okay. Wait, before we go to this, I'm just going to talk about the tactile system a little more. So your tactile system basically, when you have children who have tactile difficulties, just remember that there are different receptors that transport information to different parts of the brain that registers tactile information. Okay, number one. So number two, you have children who are tactile defensive. That is because, according to GNAS, the brain is overreacting to light touch. Okay, so light touch is not your friend as a therapist. And the second thing is that the protective reactions, like the withdrawal of hand, like if you touch something hot, you automatically withdraw. But this is so strong in children with tactile defensiveness, they withdraw from almost everything. Okay, so you need to pay attention to that as far as the tactile system is concerned. So that's why when you do the brushing, Wilbarger's protocol, or you're doing anything tactile, you have to add some amount of proprioceptive work to it as well, which is deep pressure, so that you're not over arousing the system. Okay. If you all have questions, please put it in the chat box. I'm happy to answer. Okay. So, oops. So the difficult part is mostly done. Okay. When we talk about sensory integration, we have four things we need to remember. One is the registration, which means the orientation and interpretation of information we're getting from the sensory system. Then how we integrate the sensory information and organize it. Then how we modulate it, which is the regulation, right? And then finally, how we have appropriate levels of comfort and security to a particular sensory stimuli. Okay, so this is what you need to remember: registration, integration, modulation, and level of comfort to allow for a response to stimuli. Remember the circuits that I was talking to you about? This is exactly that. It's just written out. Okay, so when we talk about sensory integration, remember sensory nourishment, adaptive response, neural plasticity, and the central nervous system organization. These are concepts. Okay. Okay. We talk about sensory diets a lot. Okay, here, because we use them as part of their home plan. Here, almost everybody comes to the clinic, has a home plan. Just really quickly, do all the kids get a home plan even at ASA? Or do most of the kids get a home plan? Okay. Okay. When you tell parents to do stuff, by themselves, do you all recommend swinging and doing texture massage or anything like that? Or do you all do it as part of your therapy? Yes. Okay. Anybody else? Okay. If you have a parent, you're advising them to do swinging, I would stop. Okay. And the reason I would stop is because you don't know if they go overboard with their child, that could be quite, they could regress. Okay. So I would rather replicate it and combine heavy work, which is proprioception, very often with vestibular work. Okay. So if, for example, we are jumping, okay, I want people to write in the chat, what is the difference between jumping in one place, like jumping up and down, not on a trampoline, jumping up and down in one place, or jumping from a stool or from the bed, top to down? I would like answers in the chat box. Okay. What is the difference? it's like a puzzle. Okay, so I'm trying to get you to think, like to solve the puzzle, right? So you need to start thinking bigger. So if I, as a therapist, why don't you all do it? Like if you all are sitting on a chair, just stand up and jump up and down. Height is the matter. Okay, where is height the matter? What will height do? You're right. Height is a component here. Various stimuli when you add it, yeah. Okay, can I request everybody to first just jump up and down in place? Okay, jump 5 times. 5, 4, 3, 2, 1, 0. Okay, now I want, yes, linear movement. Okay, now I want you to stand on your toes and bounce up and down. 5, 4, 3, 2, 1. Can anybody tell me the difference between jumping up and down like full body and jumping on your toes? Yes, Mahi. So when we jump from a height, we are using body weight and we are jumping. So we have angular movement because we are going from one position to the next, like that. So the force is different, right? You're right. And if you're jumping up and down in the same place, right, there is no angular movement. It's just up and down. Okay. Now, similarly, when you are jumping up and down and jumping on your toes, when you are jumping on your toes, there is increased vestibular input because you are balancing on a very small area, which is your toes. So when you have children on the spectrum who walk on their toes, it is because they are seeking vestibular input. They are not getting enough of it. So the toe walking helps with that. Okay. So you just need to make sure that there is no TA tightness, there is no other idiopathic toe walking reason. And they fit the sensory processing difficulty or disorder symptom so that you can help them. But does that make sense? How, as a therapist, I would recommend proprioception plus vestibular versus just proprioception versus just vestibular, because it's calming along with angular movement. So we know that they won't get disorganized easily. Is basically that doesn't mean that tomorrow you go and you do this for everybody. I'm just saying, if I had to choose an activity, I would choose this because I know that there is some security of having a proprioceptive feedback. I think trampolines are very overrated. I dislike them a lot because they can cause intense disorganization in somebody who is who has modulation difficulties. Okay, so when you are creating your diet, remember that proprioception needs to be your base and everything else needs to be built on top of it. So when we talk about an adaptive response, it is repeating something over and over again, getting feedback from the environment and finally figuring out how to do it. It's like learning to ride a bike, right? Over time, your inner ear balance is enough and you figure out, oh, this is the way I need to sit, and you figure it out. So that is what an adaptive response is. Okay, and now you talk about plasticity. Just a few things. We have 140 billion neurons, okay? And among them, there are 80 million fibers connecting the two hemispheres, the left and the right. At any point of time, we have only 1/10 of the neurons that are active. And the maximum changes before, they would say were 9, but now research is showing that even as old as 12, children have very significant changes up until 12 years of age. Okay, all of our arousal, okay, the sensory arousal is through the brain stem. Okay, the brain stem is basically the reticular activating system, RAS, is located in the brain stem, and is responsible for around, like waking up in the morning and going to bed, feeling sleepy and all that. Okay. It processes different sensory information, because remember that all the information is coming from the different parts of your body through the base of your brain, through the brainstem into the higher functioning areas. Okay, so if a child has difficulty with sensory integration or sensory processing, they could have academic difficulties, fine motor issues, self-esteem issues, learning disabilities, anxiety very often. So there are a whole bunch of things that could be wrong because of it. So you need to pay attention and try and figure out the best solution based on symptoms. Okay. Do we have questions at this point? I will talk to you towards the end based on our time on how to create a good home program. We will do more about activities in the second session at a later point of time, but this is fairly heavy what I'm telling you today. So if you understand this, I'm sure you're providing them with a lot of activities already. You will know what to provide when. Do you have any questions right now? No? Okay. We already discussed this, right? Saying that the dysfunction can cause issues with attention, learning, motor planning, social skills, motivation, and frustration. So here we have the sensory quadrants. Okay. You have low, the energy level is low, and you have the energy level high. Here you have the sensory level is low, the sensory level is high. Okay. So what this means is you have an avoider who's oversensitive and their energy level is low. So they're anxious, they're quiet, they'll just sit in one. So you remember I said some people just sit like a potato or a sloth. So they would be low sensory. So they're avoiders, sensory avoiders, and they have low energy levels. Okay. Then you have the high energy levels and you have the avoiders. They're angry, they're serious, they're impulsive, they're temperamental, they're very fussy. Okay, they would fit over here. Then you have a high sensory threshold and low energy level. So they're disinterested, they are fatigued very easily, they're lethargic, they're unaware of what's happening around, they're the dreamer child, and they're the couch potato. Okay. And if you have a bold child, high sensory seeker and high energy level, extroverted risk taker, insensitive, so they could come across as being super rude. They'll say something in your face, like they won't care what your feelings are. They could seem very undisciplined and non-polite, and hyperactive. Okay, do we have questions with this? So there are two components. One is the energy level and the other is the sensory level. Okay. Any questions? Okay, so if you have an under-responsive or over-responsive child, remember it is basically they are not reacting enough or they are overreacting. Could be two ends of the spectrum. Okay, they're either seeking or avoiding sensory feedback, which means they're constantly touching, or they're just sitting like this and they don't like playing with paint and things like that. It takes too much of sensory feedback for them to calm down and be happy, or it doesn't take much and then they get very upset. If that is the case, if they get upset very easily, it is called sensory defensiveness. When you have the under-responsive child, they are unaware of pain or touch, okay, very little. So you have a lot of parents telling you, oh, he fell down, but he's so good, he doesn't cry only. That's a problem, okay. They are very messy often. They don't realize that their clothes are not put on straight. They're physically messy. There's a lot of food on their face. They can physically hurt others because they don't know how much force they're putting. So this is the under responsive child. Okay. They could have in your face behaviors where they're constantly doing things that seem rude. They love messy experiences very often and can play with it for a long time. They could be biting to get stimulation very often, biting cuticles, biting skin, biting hair, twirling hair, chewing on fingernails, collars. So we have a lot of kids like you wear pendants or the black daga with so I'm Christian, so we wear medals and things like that. We see a lot of kids who chew that. So you would need to provide like a chewy tube or something like it that would help your child. Okay. The over responsive child doesn't like excessive stimulation. Okay. Doesn't like washing their face, doesn't like a hair bath, brushing teeth is a problem, hair cutting is a problem. They want their skin covered as much as possible. They have meltdowns very regularly. There's a lot of defensiveness. They hate messy activities. Okay. And clothing also seems to trigger them. Now, let's specifically talk about the movement or hypersensitivity to movement. Okay. Now, they prefer to sit in one place. They don't like heights. They don't want their feet off the ground, or even stair climbing is difficult. Very often we see children holding the side of the wall and climbing up. They fall down and get upset, fall down and appear very clumsy, and they don't like turning. So these rapid angular movements, especially in the same plane, is very difficult for them. And then you have the under responsive child who will constantly, you see them in the classroom, they're constantly shaking, or they're shaking their leg, they're tapping on things, they're jumping from one place to the other, and they love quick movements. Okay, so this is the hypersensitive or sensory seeker. Guys, I feel like I'm going quite fast with this because we've done it, in different ways earlier. Do you all have questions at this point? I have a lot of content today, but I feel like to create a good home plan or to create good therapy goals, you need this. So this is a good chance for you all to ask questions. Okay. Anybody has a question? No? Is it too much of information? Okay. So this is a cheat sheet that I have here for you. Okay. With some alerting and calming activities for children based on what their issues are. Okay. So alerting, which means you have a child who seems phased out. So very often giving them a crunchy thing or a chewy tube could help. If you have somebody who requires calming and is constantly talking or humming, sucking on something like a chewy tube again. Chewy tubes can be used in multiple ways based on the texture. Can really help. Alerting, sour and salt work really well. I would avoid the herbal tea or coffee. We don't want crazy hyperactive children everywhere. Bland foods, I would avoid sugar again. Bland foods or fruits are a good option here. Okay, temperature, cool and warm. Okay, heavy work is your friend. So orally, you would basically do sucking on smoothies through straws, water bottles, and here you would do chewing gum or chewing foods. You can use a lot of the things from here to basically help you create your home plan. So you can take a picture of this. I'm sure it's available later. Yeah. I honestly hate light touch, so I do not recommend it for anybody. Okay. Um, if you want something alerting, like if you have a really low arousal child, um, I would still use like a cotton cloth massage or something like that, but I wouldn't use just light touch because I think it's fairly variable. Okay, they also use tapping, and if you haven't done it the right way, you can cause issues. So I think just light pressure is fine, but be cautious. Okay. Calming, bear hug. I use burritos a lot. I don't know if you all know what that is. The child basically is wrapped in a like swaddling, how we do for babies, swaddling in the same way, and then we massage, and that works really, really well. We can also do it in a yoga mat, and a lot of children with difficulties in tactile processing or proprioceptive processing will laugh while doing this. Okay. And as they get better, you will see that they don't want as much pressure, or they don't want they don't want they don't laugh as much as before, but it's very enjoyable to them. So I think burrito wraps, bear hugs, body rolling is the same thing, is something that can really be helpful. Okay, now there is a strong correlation between cold water or cold um, and depression or anxiety. And what they found is if you immerse your face, it only works on the face and upper body. If you immerse it in ice for 3 consecutive days, changes occur at the level of the mitochondria to allow you to tolerate colder temperatures easier and decrease depression and anxiety as well. Okay, that's what new literature is saying. I don't know how feasible it is to have a child dip their face in ice water. It might seem like torture. But using, toys that have been that are cooler to touch or have been like using ice for transfers, these might all be good ways of incorporating fun play and getting them more motivated, especially if arousal is low. Rough and prickly material. I think this is a good idea. You could, when prickly, we can use loofah, we can use khadi, or the duster material. In the olden day, when I say olden days, when I was a student, I had therapists around me who were using the scrubbers. That is torture. That is absolutely not okay. Please, if you are using it, stop. That is not recommended at all. Wilbarger's protocol, if you're trained, you can use it. But again, I think you need to be trained to do it appropriately, because it can lead to hyperactivity, it can lead to crazy laughing, it can have some side effects. Yeah, natural cotton, soft terry towels, the fibrous ones, they are good for calming. Vibration also, if you're using vibration, just be careful. We use vibration on the mouth in very low frequencies. So on the body also, if you have a floppy child, that might work. But from a sensory processing perspective, we used to use a hand massager that had low frequency vibration, and children responded really well to it. So if you can find something like that, it's a good idea. Okay, fast movements. So again, here if you're doing ball bouncing, for example, you'll do really quick ball bouncing for a minute and stop and try to get them to perform a task. And then after 2 minutes, again, maybe do 30 seconds of ball bouncing, right? And have them do a task again. So it's not continuous 100. So I mean, I have some centers where the therapist will recommend 100 quick bounces. That's not okay. That is definitely not good therapy, and that is definitely not okay. So you have to alternate your vestibular with heavy work. You have to alternate your vestibular with a performance task. Okay, all the time. For movement, aerobic exercises, power walks are great. Isometric exercises like yoga are good to calm children down. Saying all this is good is fine. Incorporating it is harder. So I think you'll have to play around with some of the activities before. I don't know if you all use weighted vests at all. We use it quite successfully, compression weighted vests. They're quite expensive. They're quite expensive. 7,000 to 9,000 for the good quality ones. But very often they can, if used correctly, be very calming and help kids a lot. Assuming that it's not too hot to use it. Okay. Even rocking chairs and swings under supervision, and I think you should associate that. So, for example, if we were using, maybe in the next, when we do interventions and creating a plan, I can do some videos for you all at that point of time. But when we're doing rocking, right, I have a T-swing. I use that fairly often for when you do the correct kind of vestibular stimulation. There is also increased verbalization because there's activation in the same center of the brain. Okay, so we do a lot of heavy work on the T-swing where he or she is doing sit-ups, reaches, transfers, and maybe singing a song or something like that. So there are multiple things incorporated in that one activity. I feel like I've been talking for a long time. I hope you guys are okay. Okay, the last two things that I'm going to talk about are sensory processing and executive functioning and ADHD. Okay, executive functioning is basically the skills that we use, like I said, the prefrontal cortex. It's very higher level functioning. Okay, and when you have sensory processing affected, very often executive functioning is also affected. So, impulse control is an issue. They blurt out things, they might be engaging in risky behavior, they have meltdowns very often, they can't process what's being said very well, um, they're very rigid in the way they think. So but why did she say that, but why did she say that, I don't understand, but why did she say that? So there's a lot of ruminating thought. There's poor working memory, so remembering directions becomes difficult. 2 and 3 step instructions become difficult. um, they have poor monitoring skills. For example, they think they know everything when they don't, or they might respond badly to negative feedback. Planning things in organization is very hard for them. Beginning a task is also very hard for them, and organization is hard for them. So there's a very big overlap between high functioning ADHD and difficulties with executive functioning. Okay, so you need to keep this in mind, and there is an overlap with SPD as well. So here we know that organizing, focusing, regulating, managing frustration, working memory, monitoring self are common things that we also see with ADHD. So children with ADHD very, very often have difficulty with executive functioning. And even in children with ADHD, remember I told you about the motor neuron component. Hold on. The default mode network, right? So this is also very strongly, very, very strongly affected in children who have ADHD and executive functioning difficulties. So there's a fairly strong overlap between the two of them. Okay, so now we are going to go back to our cases, and I would like you to list down all the difficulties that you are seeing in the child. Okay, in the chat box. Are these all therapists? everybody who is attending today, like the 40 people we have here from ASA? Selin?
Yes, ma'am. Could you repeat?
Is everybody here a therapist at ASA?
Yes, ma'am. Everyone.
40
Some of them from BBR, ma'am. Village based.
VB village based. Okay, okay. But all from like all belong to the same organization, right?
Yeah, yes, ma'am. Everyone belongs to us.
Okay. I am going to, okay. She takes a long time to finish her schoolwork. Let's talk about each of these issues one at a time. All right. She takes a long time to finish her schoolwork. Why do you think she would take a long time to finish her schoolwork? Because what sensory systems do you think are affected? Correct. So you guys are right about the tactile hypersensitivity with glue and sand, but let's talk about this. So she takes a long time to finish her schoolwork. Okay. So why do you think that's happening? Poor attention. Okay. So with sensory systems might not be working. Right. With sensory systems are not working. So assuming the teacher is talking, she's copying from the board with sensory systems. Visual, yes. What else? The teacher's talking. Auditory, very good. Correct. Right. And she sticks with it, which means that it's probably like her attention, like you'll have said, is taking too long. So the combination of all these things together is just not working well for her. And lack of perceptual skills too. Very possible. Okay. She appears very quiet in class. Now there could be many reasons for her being quiet in class, right? One of the issues could be she's not processing all the information the teacher is telling her, so she's getting lost. So auditory processing is difficult for her. So now next, she leans on the table and stares into space. What is that? Holding the pencil in hands. Very good. Yes. So now when we say that she's leaning forward on the table and staring into space, what does that mean? So what is this? It could be postural. From a sensory perspective, what else do you think it could be? So when you're leaning forward, it could be that she's seeking feedback, proprioceptive feedback to stay alert. Okay. So she's probably phasing out very often. Okay. So she's low energy and low sensory, lack of processing sensory information. Correct. So because of that, she's probably wanting that sensory feedback to feel a little alert, and she's staring into space because she can't follow through with all the requirements. Okay, you'll have already said for the craft activities, the glue and sand painting, it is tactile. Correct. She's defensive. Correct. Okay, now when we say she's clumsy, what does that mean? She's clumsy, so she's tripping. It could be vestibular. Yes. Position in space. What is position in space? Also, our position in space is proprioceptive, right? Um, Correct. Right. So she could be bumping into things also because she can't perceive. Correct. She can't perceive how close or far. So sometimes, I don't know if you all have experienced it, but you have people who come very close to you and talk to you, right? That is because they can't perceive personal space, which is a problem. Um, yeah, and in these children, it's even more than that. Okay. Now let's go to Z. Okay, he gets up, hardly ever sits in his place. So what do you think? That is because of what seeking? What type of seeking? What sensory seeking is this? Correct, vestibular. Constantly playing with a rubber band. What is that? Very good, tactile. Tactile. It could also, and if they're pulling it, if they're pulling the rubber band, correct, it's proprioceptive. Correct. Okay. Absolutely right. Okay. And the rocking back and forth, vestibular. And the work is off the line. The work is off the line when he is copywriting. Perfect. Eye-hand coordination, visual perception, visual processing. It could be a whole bunch of things, right? Yeah. Okay. So now what I would like you to do is, if you have any questions about certain, so I think another important piece for you all to remember is that a lot of what we discussed is sensory and behavior are different, right? Head banging. Head banging is one thing, spitting is the other thing I'm just going to highlight on. If you have head banging, if you are sensory seeking for this movement, fine. I understand head banging as being a sensory seeking behavior, but typically you need to be able to discriminate between a behavior and sensory seeking. So if you're giving deep pressure, um, if you're giving rotation, if it is sensory, that should decrease and go away within a month. You shouldn't see that anymore. But it is harder to get rid of the behavior as compared to the sensory problem, is what I think. Okay. Does anybody have questions? We're done. I'm not doing any more today. It's a lot. Does anybody have any questions? No questions or any difficulties that you all have with children that we can talk about right now? Yeah, let's do that. Let's create a treatment plan. That's a good idea. Okay, so now we've said that the child is jumping around in one place. A lack of exposure to lack of exposure to
Ma'am, they always seeing TV and mobile phone. Due to that, also this pervasive development disorder is happening. Like
correct, but then they are triggering, so absolutely right, but then they are triggering sensory systems which are very deprivation, which is very similar to SPD. So it is SPD then. So it's not really a cause right now. They've not identified it as a cause, but very often children who are given the phone and who prefer that to interacting with people have pre-existing triggers in place, right? So they are more prone to, it's like a switch. So even in ASD, what they've said is a lot of children are born normal, and based on environmental stimulation there are triggers at 9 months, I think 16 months, 2 years. So typically even when you're making notes, you will see the parent will report he was fine until he was 2 years, and then all of a sudden he stopped talking, right? So these are like automatic switches. So if you at one point of time just stop um, uh, stop interacting with them and give them the iPad or the phone, it over like a week to 10 days can switch on the thing that causes the trigger for sensory processing difficulties. Yes, Lakshmanan.
To control the behavior, ma'am. The ADHD child.
Yeah. So behavior. So behavior very typically, right, is not behavior. It's a sensory issue in children who are hyperactive. They're moving around the room. So we need to distinguish between the two, sensory issues and behavior issues. They occur together, but we need to address them differently. Once the child is processing information better, automatically a lot of the behaviors get better. Okay, but if you have a child who is, for example, like we said, no, Z, jumping around, climbing, I would do a lot of heavy work with them. Okay, so if we had to list all the proprioceptive heavy work that we had to do, what are some of the things that you all do with your children over there? Can somebody list what they do for therapy? Definitely no swings at all in the beginning. Okay, I've learned this over time, but swinging initially, at least for the first month, is not something I would recommend. Yeah. Okay, what I typically tell parents is no sugar items, no packaged foods, and you are going to increase physical activity, which also releases dopamine and calms the child down. Okay, and you're going to do it in a regular basis. So for example, if you have swimming available, half an hour of swimming every day. If you have if it's possible to go for a walk, we are going to go for a 45-minute walk, right? This 5-10 minutes is not going to do anything. If you are in a therapy setup, right, so whether they are coming to you for therapy twice a week, thrice a week, they have to do work at home. Just you seeing them for 2 hours every week or 3 hours every week or even 5 hours every week is not enough. For the neural pathways to change, they need to do about 20 hours of therapy a week. and the 20 hours is primarily homework. But that does not mean giving them exercises. That means, for example, if they are having a bath, they have to lift the bucket, the tumbler or whatever over their head and pour the water. That is heavy work because it is a weight, right? So they have to pour it on top. If they are going for a 45-minute walk, they can initially start with a backpack with half kilo in it and go for their walk. And once they get accustomed to it, maybe you can increase it by 200. These are just examples I'm giving you. This is not a prescription. Okay. Lakshmanan, is that making sense, or does that help with some of the ideas? You know, older.
Okay, thank you.
In the olden days, what they would do is do puzzles, sit down, let's do activities. That does not work. Sitting down and doing activities for hyperactive children does not change anything. Okay, you have to do motor tasks, you have to do obstacle courses, you have to do animal walks in the session. Okay, you have to do things like jumping jacks. You have to be physically active and have them, you know, copy some of the things that you are doing. Only then will there be a change in performance. Okay, correct. So when we talk about sensory processing, remember that whether, I know there was a long list of hyperactivity, Rett syndrome is similar, right? It's on the spectrum, but if you have ADHD, if you have meningomyocele, if you have CP, if you have any of these disorders along with sensory processing issues, based on what sensory symptoms you are seeing, your intervention stays the same, right? So if you have some child who is flapping, right? Assume they have Down syndrome and they are flapping. So they are proprioceptive seeking, they are vestibular seeking maybe, right? So all the interventions that you do will be to address these two symptoms, keeping in mind that they have low tone because of Downs. Does that make sense? Does that make sense at all? I'm specifically VA. I don't know who VA is. Okay. How to control behaviors like temper tantrums and biting. Okay. Maybe we need to do something on behavior. I feel like first we'll do the second component of the sensory processing at some point. So behavior management is difficult to understand because there are many principles that go into it, right? We understand that there is an issue, but we start with a visual schedule. So you tell the child visually that we are going to do this, we're going to, so you have, it can be, do I have a picture of a visual schedule? It can be just, you know, 5 or 6 things in the session that I am share and show one. Okay, so for example, there are some websites we draw it on the chalkboard. Okay, so they will have one sticker, they will cut this out, they will laminate and put a small sticker at the back for school, for bus, for brushing in the morning, and then they do they say that these are the 5 or 6 things that we are going to do based on what the schedule is for today. So I'll give you an example of in the clinic what we will do, right? So if we are sitting on the swing, we put a swing diagram. If we are going to do something from a book, we'll draw a book. If we are doing rock wall, we'll draw the rock wall. So like that, we do 3 or 4 activities and the child goes and ticks it as soon as it is done. So they know what to expect next. Very often in children who are on the spectrum or who have ADHD, not knowing what's next causes anxiety and makes them hyper. So having this visual schedule can in itself be a good idea. Does that make sense? Yeah. So for biting, self-biting, I think first you need to figure out if the activity that you're doing is too difficult for the child. Okay. If it is too difficult for the child, then you need to break it down a little more. Okay. And you can incorporate a timer. Do not have any reaction to the behavior that you're seeing. Do not tell them to stop. Just tell them that, you have 20 seconds more on the timer. We're going to work through this. Let's see how it goes and figure it out from there. Okay. Anybody have any other questions I can help you with? The website name for the visual schedule. Let me see if I can show you if I have it on my phone. 1 second. Okay, so can you see this is how we do some visual schedule sometimes? We just draw it. And this is the clinic, right? So we have 45-minute sessions. They've done 10 different activities, which is fine. They're all addressing similar goals. And we tell the person how many times we expect it done. Can you see? Yeah. Puzzle, dominoes. On the ball here, the person is doing Superman, jumping jacks, bear walk, handstands. Okay. I hope this was helpful for you all. I hope this was helpful. The idea is that you understand why things happen so that you can better treat and do an intervention. So now you can identify the problem. Once I tell you what are the different things that you can do, it'll give you a better idea in terms of how to select the right activity for your child. Increasing screen time of a child below 2 years will not lead to SPD necessarily, but is bad because it's decreasing environmental interactions and it can cause a lot of problems because of that. So vocalization will be, they're not interacting with humans, right? So again, like I said, they are the DMD is basically shutting down. So they're hyper focusing. Because of the hyper focus, they're shutting down the environment. So they're not paying attention. So it is more likely that it could trigger sensory processing difficulties. I'm not saying it will cause for sure, but there is definitely an increase in the recent time because of COVID and younger babies getting screens. I hope that answers your question. Celine, I know we finished. At what age can you identify SPD? I have babies as young as 6 months who have sensory issues that I see in my clinic. Right, so they're 6 months old and I'm seeing them. I mean, again, like I said, I live in a suburb where identification, especially by some pediatricians, is better than others. Now we're identifying, so I work with a neurologist, a pediatric neurologist, Dr. Vijay Shudani, and he's identifying autism-like symptoms at 13, 14 months now. So the gold standard, I think, is by 18 months you can diagnose now, but you can start therapy. Nothing is going to change, right? So with SPD or with ASD, the intervention, there is no medication. So the intervention continues to stay the same. I hope this was helpful. I hope I didn't overstress you all with all the information I gave you all today. But the idea is to have a second session in a month or two, where you all review all this. You can listen to the recording again, and I will do a short review before, and then we'll create treatment plans for different types of cases. I look at the cases you sent. This is a chance. So if you have cases that you want to discuss, you can send short videos. You can send them to Selin maybe 2 or 3 weeks before, and I can create treatment plans for you. We can do this online. I will not share the PowerPoint, but I will definitely, you have the recording, so you can review this. Okay. Any other questions? Okay. Thank you. And I guess I'll see you all on Saturday when I'm doing my coaching talk. Yeah. Bye, everyone. Selin, anything else? Are we good?
That's it, ma'am. We'll close the session.
All right. Thank you.
Thank you all.
Bye.